Hello, everyone. Welcome again to our Brightening the E&M Outlook MDM Q&A activity webinar. My name is Ashley Decoto, and I am a specialist with our Provider Outreach and Education team. On the call with me today is my friend and colleague, Leanne Foster, who will be helping out with the chat. This webinar is part 2 in our 2-part series on choosing your level of service using medical decision-making for evaluation and management services. Yesterday, Leanne held the part 1 webinar, which provided more of a comprehensive overview on medical decision-making. Now, if you were not able to attend that session yesterday, that recording will be available within the next week or so in the Training Center on our website and on our YouTube channel. We will also have a recording of this session available, also on the Training Center on our website, and Leanne will be adding a link for that Training Center to the chat. And it will be available there on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can access this one without having to access YouTube, as we do recognize that not everyone is able to access YouTube from work. The recording will also be available, though, on our YouTube channel, and it will stay out there as long as this information remains relevant and current. Another thing in our training center, you can find a copy of today's presentation. So if you haven't already grabbed that, it is still out there available for download in case you'd like to have the presentation to follow along or maybe to take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring. I will check in with Leanne at the end of the presentation, time permitting, for any unanswered questions in the chat. We did have quite a few questions that were pre-submitted with registration, and I will be answering those throughout our presentation today. Now, if for some reason we do not get to live chat questions, we will answer those in a follow-up email. All right, for our agenda, we will start by doing a brief recap from Leanne's Part 1 webinar yesterday. Then after that Part 1 recap, most of our session today will be the interactive Q&A activity. And then lastly, I'll share a few resources. So this 2-part series is meant to be more of a higher level overview on choosing your E&M level of service using medical decision-making. While we will be talking about each element of medical decision-making at some point today, Leanne and I also have 3 additional series, and they're scheduled in the coming months, which will drill down into each component of medical decision-making and provide kind of a more in-depth training. So we'll have a series on problems addressed, we'll have one for data reviewed, and then one on the risk element. So make sure you stay tuned to our live events page for registration. And if you're not able to attend any of those, like with most of our webinars, we do plan to post recordings, barring any technical issues, of course. Okay, let's get started with a recap from Leanne's session yesterday. So when you're choosing your code for an evaluation and management service, you can use either the time spent for that encounter or the medical decision-making. Today, again, we're focused on medical decision-making. Now, Leanne and I did a series earlier this month on using time to choose your level of service, and I have asked Leanne to place links to the recording of those webinars in the chat. So when using medical decision-making, or MDM, you might hear it referred to as. When you use MDM to choose your level of service, you'll be considering 3 elements. The first element is the number and complexity of problems addressed during the encounter. The CPT book defines a problem as a disease, condition, illness, injury, symptom, sign, finding, complaint, or other matter addressed at the encounter with or without a diagnosis being established during the encounter. And what's important to keep in mind with this element is that you are only accounting for problems that were addressed or considered during that encounter. So even though some or maybe many of your Medicare patients might have a long list of problems in their history, you're only counting those that were evaluated or treated during the encounter. The second element of medical decision-making is the amount and complexity of data reviewed for the encounter. So the data element includes review of tests and documents, gathering information from an independent historian when needed, independent interpretation of test results, and discussion of management. Each level of data reflects an increasing level of review or analysis. And one thing to keep in mind with data is to make sure that you're not counting things that are separately reported. For example, if you're billing separately for, let's say, interpretation of an EKG, you would not also count that under the data element. You want to make sure that you're not double dipping, so to speak. The third element is the risk of complications and or morbidity or mortality of patient management. So this is the risk of patient management based on the treatment decisions made during the encounter. And this one is really important for your practitioners to document. You don't want to make assumptions on the risk level. So practitioners need to document the risk based on their clinical judgment. The CPT book says that physicians apply common language usage meanings to terms such as high, medium, low, or minimal. So if the documentation is not clear on the risk, you may choose to seek clarification from that physician. For the next bullet on this slide, most services have 4 levels of service, which are straightforward, low, moderate, and high. Or some just have 3 levels where straightforward and low are combined into one code. And you'll select your level of service based on meeting or exceeding the requirements of that level for 2 out of the 3 elements that I just mentioned. So for example, if you have a moderate level of problem, a moderate level of risk, and low data, you can select a moderate level of service because you met that for 2 elements. Another thing that becomes really important in medical decision making is using the CPT definitions for each element. And these are outlined in the CPT book and also in a CPT resource that Leanne will be putting in the chat for our activity in a few slides. So there are definitions there for the types of problems, the components of the data element, and then also for the examples of risk. We had one pre-submitted question which said, please address the difference between an office or other E&M service medical decision making and how it's different from the IPPP and the annual wellness visit. So E&M visits in the office and other types of E&M visits, such as nursing home or inpatient hospital visits, those follow the same guidelines for medical decision making. As far as the initial preventive physical exam or IPPE and annual wellness visits, those do not use medical decision making. And we will not be talking about preventive visits or annual wellness visits during this session. But we do actually have 2 playlists on our YouTube channel, one for annual wellness visits and one for preventive services, which will have some information on the requirements for those types of services. And Leanne will be placing links in the chat, if she hasn't already, to both of those playlists. Another thing to keep in mind with using medical decision making is that some E&M services allow for only medical decision making to choose your level of service, and some allow only time to choose your level of service. And we have those listed here. So level of service for emergency department visits may be chosen by medical decision making only. time is not used for emergency department services, as practitioners are typically taking care of multiple patients, so it would be difficult to track the time spent on an individual patient. Then we have those E&M services that you're not able to use medical decision-making to choose your level of service. So critical care, discharge management, and prolonged care are all time-based codes and do not allow for selection by medical decision-making. We had a pre-submitted question which asked when to use MDM versus time for evaluation and management services. Aside from the services that only allow one or the other, as we have on this slide, you can use whichever is most advantageous for you. So if coding by time gives you a moderate level, let's say, but medical decision-making gives you a low level, then you can use time to select your code. Or if medical decision-making gives you a higher level, then use medical decision-making. It's always best to take a look at both and then determine which would give you the best outcome. All right, here we've included this slide to show what errors have been found that relate to selecting level of service. 2 of the top CERT errors for office visits are listed here. And the first, this one might not come as a surprise to you, which is the error for documentation supporting a lower level of E&M. So of course, make sure that your documentation supports the level of service that's billed. Now the second bullet here might come as a surprise to some, which is that documentation supports a higher level of E&M. And the point we want to make by including this is do not sell yourself short for work that was done by a practitioner. And keep in mind that you may not have the same level of service if looking at the time or the medical decision-making and what the documentation supports. So if the documentation supports a high level of service using MDM, but a moderate level using time, again, use MDM to build that higher level of service. We did include 2 links here on this slide. The first is to a page on our WPS website with more information on E&M CERT errors. And then the second link takes you out to the CMS website where you can find a list of CERT reports. The 2025 CERT report was posted on January 24th of this year, and that's where you'll find these E&M errors. Okay, before we move into our activity, I wanted to share a quote that we really like here by Sir William Osler. It is much more important to know what sort of a patient has a disease than what sort of a disease a patient has. And this is a concept that's really important to keep in mind with medical decision making. We had a lot of pre-submitted questions between these 2 sessions asking which problem level this condition is, or asking if this is a chronic problem. The medical decision making will depend on what occurred and what was documented for that encounter. So there's not a blanket list of conditions for each problem level. So for example, a headache might not be a big deal for one patient, but it may be severe or chronic for another patient. It's important to look at the full picture and the documentation rather than maybe a list of diseases or conditions the patient has. Okay, now we're going to shift gears into our interactive Q&A activity. And we've designed this to be kind of a fun way to test your knowledge. So we'll launch a poll for each question. And even if you're not 100% sure on the correct answer, we'd love to have you participate and just give it your best shot. I'll give you a moment to lock in your answers, and then I'll walk through the correct answer for each question. Also, Leanne will be adding some reference links to the chat, and I encourage you to have these open to help out with the activity. Okay. So for our first question, there is no right or wrong answer. We just wanted to get everyone thinking about something that we know and understand can be challenging when it comes to medical decision making, which is the subjectivity. So the question we're asking here is, how do you personally handle subjectivity with medical decision making? And you can select any or all of these that apply for you. So do you A, ask the practitioner? Do you B, ask Dr. Google? C, refer to those CPT definitions I mentioned earlier and that Leanne shared for those who attended yesterday? Or D, do you ask the A word, as I like to call her in my house, so we don't accidentally trigger her response? Lots of answers coming in. Looks like we've got about 57% done. I'm going to give it just another moment just to kind of get a feel for what everyone thinks is most helpful. Okay. Got almost 70% responded, and thank you everyone for participating. These are all great resources to help you with medical decision making, and it looks like many of you are making good use of some or all of these options. Asking the practitioner and referring to CPT definitions are both solid methods to get clarification, and those were overwhelmingly the highest selected answers for this question. Options B and D here are also both great tools to help, both of which I have used as well. One thing to keep in mind, though, is that Dr. Google, as we called him, and Alexa were not at the encounter, and both of them have been known to get it wrong. So you can use these as a tool, which would be a great way to find information, but not everything they find will be correct or even applicable for Medicare. For example, in preparation for this webinar, I found a lot of things from Dr. Google that are no longer relevant for Medicare because they were based on guidelines in 2020 before significant changes were made for E&M coding. That's just something to be mindful of, though, but I don't by any means want to discourage you from using any of these as a tool. Okay, so now we'll really dig in. So our first question is, level of service may be chosen for all E&M services using either time or medical decision making. True or false? All right, we still have a few getting their answers in, just another moment. Okay, so the answer for this one is false. While most E&M services allow for either time or medical decision making, there are some services that can only be billed using time, and some can only use medical decision making, which we showed on slide 5. So for our next question, which of these E&M services may use medical decision making to choose level of service? And you can select all that apply from these options. Is it A, emergency room services, B, office visits, C, nursing facility services, or D, hospital inpatient services? Okay. So the answer for this one is all of these. You can use medical decision making to choose your level of service for each of the services that are listed here. Remember, there are some E&M services that do not allow for code selection by medical decision making, including critical care, discharge management, and prolonged care. Those are all time-based codes. Before we move on to the next question, I want to show you a resource on our website, and this will be the first link in the chat for this activity. So this page on our website gives you information on medical decision making at kind of a high level. If you're newer, this is really a good place to start. Now, if you've been doing this for a while, hopefully you're using the CPT book and the CPT guidelines for medical decision making, as Medicare does follow CPT guidelines for MDM. So on this page, first thing I want to point out is the top section, which defines medical decision making. And this may look familiar to some of you, as this is the CPT definition. So medical decision making is the process of establishing diagnoses, assessing condition status, and determining appropriate management options. Below that on this page, we have a list of activities involved in medical decision making. So we have history, examination, assessing the patient, advising the patient, and assisting the patient in managing their health. Now, notice we have history and examination on the list. Now, if you've been doing this for long enough, you probably remember that these elements used to be used in determining the level of service. While they don't determine the level of service anymore, they are still part of the process for medical decision making. Let's think about the code descriptions for your evaluation and management codes. They say requires medically appropriate history and/or examination. So the history and/or exam are still part of the documentation needed for evaluation and management. The next thing on this page is we have the MDM levels: straightforward, low, moderate, and high. And after that, we have the basic descriptions for each MDM element, meaning the problem addressed, data reviewed, and risk of complications. So I'm going to head back to the presentation now, but again, for anyone on the line that's newer, I wanted you to have this as kind of a starting point of reference and to help you get familiar with the elements of medical decision making. Okay, for our next question, which of the following are elements of medical decision making? And you can select all that apply from these options. Is it A, total time spent, B, problems addressed, C, data reviewed, or D, risk of complications? All right, the answers are coming in super fast on this one. Okay, so the answer for this one, it looks like most of you got this one right, is B, C, and D. When choosing your level of service using medical decision making, you'll be looking at what problems were addressed during the encounter, what data was reviewed and analyzed, and the risk of complications. And that leads me to our next question. So our next question is, if using medical decision making to choose level of service, you must meet or exceed how many of the elements: problem, data, and risk? Is it A, 1 of 3, B, 2 of 3, C, 3 of 3, or you can select D if you're not sure? Okay, the answer to this one is B. You must meet or exceed the requirements for 2 of 3 elements in order to bill for that level. We had a pre-submitted question that I want to talk about here, which was, do all oncology visits support a level 5 if stable on current chemo regimen? So this will depend on what your documentation supports. If the only problem addressed is the cancer and it is stable, then you likely don't have a high-level problem. It sounds like we have a chronic stable illness, which does not fit into the CPT high-level problem description. So you will need to look at the other 2 elements. You would need to look at what data was reviewed and what is the documented risk level. We had another pre-submitted question, which asked, if we perform our own vascular ultrasounds in office, how are they counted in the management of a chronic condition? And this one's also going to depend on what the documentation supports. Are you, or is your practitioner, treating a chronic condition during an E&M visit? If so, you count that under the problem element, so long as the documentation supports it. Okay, for our next question, if documentation supports a low level of problem, low level of data, and moderate risk, which level of service is appropriate using medical decision making? Is it A, straightforward, B, low, C, moderate, or D, high? Okay, I've been waiting for this moment. This is the question 100% of you got right, so this is the last easy one. The answer to this one is B. You must have met or exceeded 2 elements in the low level. So even though you have moderate risk in the example, 2 of your 3 elements, problem and data, are at a low level, so you would choose the low level code in that scenario. All right, so for our next question, this one relates specifically to the problem element. Which of the following is a problem in the differential diagnosis that represents a condition likely to result in a high risk of morbidity without treatment? Is it A, stable acute illness, B, chronic illness with exacerbation, C, self-limited or minor problem, or D, undiagnosed new problem with uncertain prognosis? I'm going to give it just another moment. We have just a few still getting their answers in. Okay, the answer for this one is D, undiagnosed new problem with uncertain prognosis. So there's a couple of things we wanted to point out with this question. One is the definitions in the CPT book. This is one of the resources we talked about, and probably your best resource aside from involving the physician. If you're newer or maybe don't have access to the CPT book yet, those definitions are also found in the AMA resource. That's the second of the links in the chat for this activity. Now, the other thing to point out here is that there will be situations where you don't yet have a diagnosis. Maybe the patient comes in with a lump in their breast, but we don't know what it is. It meets this definition because we don't have a diagnosis and the prognosis is uncertain without further treatment and testing. We had a pre-submitted question about the problem element, which said, please explain what a complicated injury is. They've never heard of examples for this. So by definition, a complicated injury requires treatment, including evaluating body systems that are not directly part of that injury. So an example of this could be a patient presenting for laceration of their scalp. And based on information from the patient, the practitioner also performs a neurological exam. Or maybe we have someone like my husband who's always injuring himself with power tools, and they present with a superficial burn on their finger from a frayed live wire. Even though the visible damage is minimal, an electrical current traveled through the body, and the practitioner performs a cardiac evaluation. So the complication is that while the presenting problem is the electrical burn on the hand, further evaluation is needed due to the potential effects on the cardiovascular system. All right, moving right along. For our next question, conditions that the patient has but are not addressed during the encounter are counted towards MDM. True or false? I love how fast those answers are coming in. We got about 50% are done. Okay, so the answer for this one is false. And this is really key with a problems addressed element. So a problem that's just listed in the history, but is not mentioned anywhere else in that note, that problem does not count. The documentation must show how the problem was addressed or evaluated in determining a treatment plan. We had a pre-submitted question that I believe is asking the same thing. This question says, does each condition in the plan of care count towards complexity, or does showing the condition was evaluated enough? So when counting a condition towards the problem element, we want to think about how CPT defines problems addressed. The CPT book says a problem is addressed or managed when it is evaluated or treated at the encounter. So what this means is you can't just count every problem listed in the patient's history, but you may have situations where certain problems are not necessarily treated during the encounter, but have to be considered when making treatment decisions. An example of this is, let's say, a patient who's presenting because they have the sniffles or they have the sinus infection, but the patient also has hypertension. The physician may be considering the hypertension in determining the treatment plan because decongestants can raise blood pressure. So we have two problems. We have the sinus infection and we have hypertension. The hypertension does count in that scenario because it is considered when making treatment decisions to treat the presenting problem, the sinus infection, but the documentation would need to support that thought process on how the hypertension was considered in making treatment decisions. Let's think about a similar situation. Maybe you have another patient who's coming in for a sinus infection. They also have, let's say, arthritis in the knee and high cholesterol listed in the history. Neither the arthritis or high cholesterol are addressed or even considered during that encounter. So you're only counting one problem for medical decision making, which is the sinus infection. You would not count the arthritis or the high cholesterol. We had one more question, which said, if a patient comes in for a UTI and provider also discusses his 3 chronic conditions, just that they have them, and run a test and refill 3 meds. So for this one, Does the documentation show how the other chronic conditions were treated or managed? If so, you can count them. But if they're just listed in the history, you don't count them. If the documentation just says refilled meds, that's not really enough for a reviewer to know how the chronic conditions were addressed, and they would not be counted. All right, for our next question. A statement in the medical record saying all chronic problems addressed is sufficient alone to show level of problem. True or false? Okay, the answer for this one is false. This type of statement is not sufficient for problems addressed. The documentation should show which problems were addressed and how they were addressed. Again, just because the conditions listed in the patient's history does not mean that it counts for medical decision making. The documentation must show how the problem was addressed or evaluated to count that under the problem element. We had another pre-submitted question on the problem element, which asked for best documentation recommendations for determining chronic versus acute conditions. So there's a few things to consider here. One is something that I just mentioned, which is making sure that it's addressed during the encounter. So for example, if you have a patient with diabetes who comes in because they have the sniffles, and the diabetes is not addressed at all, you would not count that. You would just count the sinus infection. In determining whether you have a chronic versus an acute condition, the second part of this question, you'll want to double check against the CPT definitions. The biggest thing to keep in mind as far as the difference goes is the amount of time that the patient has had or will have that condition. A chronic condition is one that has lasted or is expected to last at least 12 months. And we've had many questions in the past asking for a list of chronic conditions. While there's not an all-inclusive list, CMS does list some examples of chronic conditions in an MLN on chronic care management. And if you wanted to look at that, you could go out to cms.gov and do a search for chronic care management. So again, there are some examples of conditions that are inherently chronic, but remember the quote that we looked at just before this activity. It is much more important to know what sort of a patient has the disease than what sort of a disease a patient has. So you may have a patient with a condition that is chronic for them, but might not be chronic for me. For example, I had a garage sale last weekend and I hurt my back lifting heavy boxes. My problem is acute because the pain has only lasted me a few days, and we have no indication to believe that it will last more than a year. But a friend of mine has degenerative disc disease and has dealt with lower back pain for a number of years. If she sees her doctor today for back pain, we have a chronic problem because it has lasted well over a year. So your acute conditions are shorter term. Chronic means it's lasted or is expected to last a year. While some conditions might be inherently chronic, there are some that are not, like my back pain example, and this is where it becomes really important for the documentation to paint the picture of that problem. All right, so for our next question, we're going to move on to the data element. Which of the following accurately describes discussion of management under the data element? And you can select all that apply from these options. Is it A, interactive exchange, B, direct, C, not through intermediaries such as clinical staff, or D, sending chart notes or making notes within progress notes. All right, the answer for this one is A, B, and C. So when counting discussion of management under the data element, this must include an interactive exchange, and it cannot occur through intermediaries such as clinical staff or trainees. Sending chart notes or kind of written exchanges through the chart notes, that does not meet this requirement. Now, it does not need to be on the same day of the encounter, but you'll count it only once, and it should happen, or it should be completed in a relatively short period of time, meaning within a day or so. We had a pre-submitted question asking for a good explanation on the amount and complexity of data to be reviewed. So the data element accounts for information that the practitioner must gather and use in determining the treatment plan. Each level of data is going to reflect an increasing level of review or analysis. Data includes, again, ordering and reviewing tests, independent historians, discussion of management, and independent interpretation of tests. That's kind of a high-level overview of the data element, and we do have a couple more questions on data in this activity. You also have the link in the chat for that CPT page that has those detailed definitions for the data element. Also, keep in mind we'll dig even deeper during the series over the summer, specifically focused on the data element. So for the one that asked that question, those are some great resources to help. All right, for our next question. For this one, we have a scenario. Dr. Foster provides care in the office for established patient Betty and also bills for the professional component of a chest x-ray. Which of the following is true? Is it A, interpretation of the chest x-ray counts for MDM? B, interpretation of the chest x-ray does not count for MDM? C, Dr. Foster cannot use MDM for an office visit? Or D, Dr. Foster should bill this as a new patient visit? All right, looks like we're kind of almost split down the middle on this one. So the answer for this one is B. Since Dr. Foster billed for the professional component of the chest x-ray, she cannot count the independent interpretation of that chest x-ray for medical decision-making. It's already accounted for in billing the professional component, so you can't double dip by also counting it under the data element. We had a pre-submitted question on data, which said, when a provider documents review of a lab, such as CMP, what information do they need in the documentation to count as a review? The documentation would just show that a review of the CMP was completed and how it was used in making treatment decisions. There's no specific verbiage that's needed, just clear evidence that that review took place and what that review meant for the patient's care. For example, maybe the labs were normal and the provider documents the review and notes CMP looks great, so we will continue current medication dosage. Or maybe there were changes based on the results. So the provider notes that let's say the CMP shows low potassium, so they're prescribing a supplement. This shows the review and how the results are used in the treatment plan. All right, our next question is another scenario. Patty was inpatient at ABC Hospital from April 2nd through April 12th. Dr. Bob reviews notes from the cardiologist and neurologist. Which of the following is true? Is it A, review of these notes counts as one unique source? B, review of these notes counts as two unique sources? C, Dr. Bob cannot use MDM for an office visit? Or D, maybe Patty should find a new doctor? Got a couple still thinking about it. Just another moment. Okay, the answer here is A. Review of these notes counts as one unique source for the data element. ABC Hospital in this example is one unique entity, so review of notes from that hospital stay count as one unique source. We received a question regarding the data element, which asked for the documentation requirements for an independent historian. For this one, CPT requires that an independent historian be an individual who provides history for a patient who is unable to provide a complete or a reliable history. So this is not a situation where the wife has tagged along for her husband's visit, a husband who is perfectly capable of providing his own history. Instead, this could be maybe a patient with dementia who is unable to provide a reliable history, or, though we don't see it too often with Medicare, a minor who's too young to provide the needed history. You want to make sure the documentation shows why the independent historian is needed. So it might say, Dr. Bob spoke with Patty's daughter because Patty has dementia and was unable to provide a reliable history. All right, for our next question, risk level for minor or major surgery is based on the global surgery period. True or false? All right, the answer for this one is false. The risk level is specific to each patient for that particular surgery and is based on the practitioner's clinical judgment. We had a question regarding risk, which asked for details specifically on decision regarding minor surgery with versus without identified risk. So for the moderate risk level, CPT gives the example of decision regarding minor surgery with identified patient or procedure risk factors. What this means is you have a practitioner who's made the decision that surgery is needed, one that would typically be considered a minor procedure. But for this particular patient, the practitioner has identified that there are certain risks that are not usually associated with that minor procedure. Let me give an example. Let's say a physician has decided to perform an incision and drainage of an infected cyst on an otherwise healthy 25-year-old. So in this case, we have no identified risk factors. But let's say a physician made the decision to perform that same procedure on a patient who is immunocompromised due to active chemotherapy, putting the patient at risk due to their compromised immune system that would be unable to fight off bacteria should that infection spread. That would be an identified risk for a procedure that would otherwise be considered minor. There's a risk that's specific to that patient, in this particular example, due to a compromised immune system. We had another pre-submitted question regarding the risk element, which asked for an explanation on high risk of mortality. So high risk of mortality under the risk element is about the high stakes from the treatment plan, not just how sick the patient looks. So when looking at the treatment being considered during that encounter, does that treatment result in the possibility of death or permanent life-altering disability if something goes wrong or if the condition is left untreated? This doesn't necessarily mean that there's a guaranteed catastrophe as a result of the treatment. The CPT book tells us that a low probability of death may be a high risk, whereas a high chance of a minor self-limited adverse effect may be a low risk. So it's important, again, for your physicians to document what the risk is. Based on their clinical judgment, is the patient at high risk for death or some type of adverse outcome based on treatment decisions? Meaning, what is the consequence or what is likely to be the outcome of proceeding with or without that treatment? All right, we have a couple more. For our next question, which of the following are true about prescription drug management? And you can select all that apply from these options. Is it A, over-the-counter drugs may be included? B, always moderate risk? C, physician must assess and document risk level? Or D, a note that medication list was reviewed is sufficient? Okay, it looks like most of you got this one right. The answer here is A and C. So over-the-counter drugs may be included in this, but the risk of that drug would need to be documented. Prescription drug management is not always a moderate risk. The CPT book lists prescription drug management as an example under moderate risk, but that's the key here. It's an example. The practitioner must document the risk level of that drug for that patient. Just making note that the medication list was reviewed does not automatically give moderate risk level. Again, that risk must be documented. We had a pre-submitted question about prescription drug management. If the provider documents that they discussed over-the-counter drugs to take, including alternating Tylenol and Advil, but no dosage or instructions, can we still credit that? And the answer to that is probably no. If there's no documented risk from taking those over-the-counter drugs, then that would not count. For a healthy patient, there may be little or even no risk for taking over-the-counter NSAIDs, but for some patients, these may be risky, and that needs to be documented as to why there is a risk. Another question asked, does stating continue losartan and documentation equate to prescription drug management? So if the only thing documented is to continue the medication, that does not give moderate risk. The risk level, again, needs to be documented. So if there are certain risks to the patient by continuing that medication, that should be documented. If it's not clear, you'll want to seek clarification from the practitioner. And again, it's really important for practitioners to document that risk. Keep in mind that even though prescription drug management is given as an example of moderate risk, risk is the element that even the CPT book specifically says must be documented by the physician. And they can use common language again, such as high, medium, or low risk, but it has to be documented. Okay, for our last question, and I know we're running tight on time, so we'll get this one done. So our last question is, suggesting a patient go to the ER counts as decision for hospitalization under the risk element, true or false? All right, the answer for this one is false. If the primary care physician tells their patient to go to the emergency room and the ER physician then makes the decision to admit them, the primary care physician did not make that decision. It would not count it as such. Keep in mind that the physician who makes that decision is who would count it, and the risk level would be documented. Now, for high risk, CPT lists decision to hospitalize as an example. While this is an example of high risk, the documentation should still show what the risks are for that patient. What is the practitioner's thought process? What are the risks for the patient? We had a question kind of along these same lines, which asked for an example of decision for hospitalization, which again is an example CPT gives for high risk. So you'll want to make sure the risk is documented. For example, maybe the physician recommends hospitalization for a patient with severe COPD who's having a severe exacerbation and oxygen levels that are dangerously low. The physician decides to hospitalize them due to the high risk of respiratory failure without hospitalization. Or maybe you have a diabetic patient with severe skin infection on her leg, and she has a high fever. Oral antibiotics have not worked, and the physician decides to hospitalize for continuous IV antibiotics due to risk of sepsis. That needs to be indicated within the documentation. If the risk is not clearly documented, coders and billers should involve the physician to get that clarification. I had one more pre-submitted question, this is the last one, which was, if an urgent care provider decides to transfer a patient to the emergency department, would this be moderate risk? So again, the risk level would need to be documented. Transferring the patient to the emergency room, that would not be considered a decision regarding hospitalization, so it doesn't fall under that example of high risk. But as far as moderate risk, what does the documentation show? Is there a moderate level of risk to that patient based on treatment decisions that were made by that urgent care provider? What are those risks? That information needs to be documented to make sure that it's clear to a reviewer. All right, and I see we are right at an hour, so we've got a couple slides there with some resources for you. And then just a few things I want to mention before we disconnect today. I will send out an email, first of all, if there are any unanswered questions in the chat. So just please don't worry. I want to make sure that you get answers to those. If you do think of any additional questions, you have 7 days from today to submit those, and you'll send those to our education mailbox, and make sure to include the title of the webinar, Brightening the E&M Outlook, MDM Q&A activity in the subject line, or you could just shorten that up to medical decision making part 2 or something to that effect, so that they make sure those come to Leanne and I. Please keep in mind that we're not able to access any claims history, so you will want to contact customer service for any claims related questions. In a few minutes, you will receive an email to thank you for attending, and you don't want to delete this one without reading it. This contains your certificate of achievement, so it will have your name and contact hours if you need to turn that in for credit towards continuing education units. If you do not receive the email, a few things could have happened. First, you may want to check your spam or junk folder, And be sure to add messenger@webex.com to your safe sender list so any future messages will show up in your inbox. Also, if you joined by phone only, you would not have received the email, as there's not a way for us to capture your email systematically from our attendance record. But no need to worry. If you did join by phone, you're able to email us with the phone number that you joined with to request your certificate of attendance. And Leanne will be adding that email to the chat. All right, last thing. Please take a few minutes to complete the survey. You can tell us what you liked today, what we can do better. You can suggest topics for future education. You'll have a few different options to take the survey. You can use the link in the chat, or when you exit today, you'll be prompted to go to an external site, and that external site is the CMS Qualtrics page. And you'll have a prompt that looks similar to the picture we have shown here with that little yellow triangle. We included that image so that you know this is safe. It's not malware or anything like that. If you're listening through our website or through our YouTube channel, you do have that same opportunity to provide feedback. You'll have a survey card at the end of the presentation. You can scroll to the end to see this, or it's also available in the description. Okay, that concludes our webinar. On behalf of myself, Leanne, and all of Provider Outreach, we thank you for taking the time to join us. We truly appreciate your participation in the Q&A activity, and we hope to see you at future events. Everyone have a great afternoon. You may now disconnect.